Faith-Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Welcome to Healthcare Musings, everybody. Happy to have you with me. I am delighted to have Dr. Safwan Halabi on the show. He is a assistant professor of radiology, of pediatric radiology at Lurie Children's Hospital here in Chicago. He's also a clinical informatics expert, and he is an expert with the with the Radiological Society of North America with respect to clinical informatics. Why I wanted him on the show, because even though I'm not necessarily, I don't work in pediatric critical care medicine, and he is, as far as I'm concerned, a subject matter expert with respect to AI and AI in medicine and AI in radiology. And I also want to just talk about, he's at the end of the day, he is an expert in radiology, and to talk about things, how we as clinicians, practicing clinicians, can work better with radiologists. So welcome, Dr. Halabi. So happy to have you on Healthcare Musings.
Thank you so much, Hisham. We're really delighted to be here.
Oh, the honor is mine. So let me ask straight out. Are you looking for another job because AI took your job away?
No,
Have you
I
started
think
collecting unemployment? Or?
that's a great question. I think many people have predicted that radiologists would not have a job here in the near future, or at least 2025. But I can say with confidence that AI has been augmenting the way that we function and is actually providing a lot more data that we have to sift through as subject matter experts or subspecialized in whatever pediatrics or even different types of imaging to make sure that the AI is actually accurate. And we've seen that even with just general our large language models and things like that. We can't fully trust them, and we do see a lot of hallucinations that the AI is generating.
So define what hallucinations mean for those who are not as familiar with that term with respect to AI. Is like, are the AIs on drugs or something? Explain what that means.
So the artificial intelligence is obviously taking in information to synthesize, something that you prompt it to spit out. And if it's really grabbing from all different types of sources, and it sounds very authoritative, but in the end of the day, there are definitely many mistakes and things that it may not know very well or may not synthesize together very well. And so those hallucinations come out as very authoritative, but very misleading and wrong and false.
Because it can't say I don't know. It just makes things up
Yeah,
if it doesn't,
it
if it
has
can't
to
find
give
it.
you something, right? And it won't say that I don't know, and it will give you an answer, and it will provide you with something that sounds very legitimate. But when you peel away the layers, there's definitely some fallacies and some misinformation.
Wow. Because I think part of what makes a good doctor a good doctor is to sometimes say, I don't know, right? And it's just interesting how AI is not programmed to do that.
Correct. I think AI it's touted as being able to tell you anything at any time from any source, but there are definitely certain things in medicine where, you don't know where the references are coming from, and we don't have the answer for a lot of things, and we don't have certain pathways that are vetted by, experts, whether it's treatment protocols or even algorithms to diagnose diseases by imaging. And many times, anybody that has dealt with radiology or imaging reports, we oftentimes have to give a differential diagnosis or at least, synthesize the information, the clinical information we have to give some type of opinion.
Okay. So do you feel that artificial intelligence has enhanced your product as a radiologist?
I
Like
think, yeah.
where do you see it going 5 years from now? I mean, I know it's impossible to predict the future. And what's your sense of how it can make a radiologist better?
There are different ways that AI is enhancing the way we practice, everywhere from, looking at just image capture, so using denoising kinds of things, using less information to provide better fidelity around imaging, so using less dose, using less radio tracer, using less scan time to enhance the images that AI is doing in the background. So there's that piece. That's sort of the non-interpretive piece. And then everyone is obviously looking at, can it diagnose things on an image? And so it will detect things like fractures. There are many FDA approved algorithms today for like pulmonary embolism or intracranial hemorrhage. And then there's the whole reporting side. So there's the whole, can it clean up and find mistakes? Like if we say uterus for a male or right left issues, I think there's going to be a lot of things where it'll reduce errors and hopefully guide us to better diagnostic abilities, and also be a second pair of eyes for that radiologist that may not be looking at everything, or we're looking at thousands of images, right? So
Mhm.
having an algorithm or another system that's looking at that can be very, very helpful, but it has to be vetted and it has to be approved.
Right, right. Because I recently had a case where the initial CAT scan of the brain, this is a patient who suffered cardiac arrest, the initial CAT scan of the brain was read as normal. When I looked at it, I didn't think it looked normal. When the neurosurgeon looked at it, he also said it wasn't normal. Is that something that you think like an AI program can help to point you, hey, this does not look like a normal scan, or look, I think I see nodules here, 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 things like that?
Yeah, I think that's exactly what it can do. It can detect things like, I think it's very good at brain hemorrhage. I think it's good at pulmonary embolism. Nodule detection, it's very monotonous work, but the AI can capture a lot of it. Now, the question is, are we over calling, or are we catching every little ditzel? And what are we going to do with those? So I think that's where it's going to be very interesting, to where if the AI does flag something, who is going to be the adjudicator? What's the gold standard? Who's going to act on it? What's the final? Who has the final word? Is it the pathologist, or is it
Right.
somebody else that looks at it? So I
No.
think that we're seeing more and more of these tools being integrated in our daily practice, but it has to be used like any other tool, right? Like
Mhm.
whether EKGs have long time been automatically interpreted, right?
Right.
And how often do people feel like that's accurate, or do people look at the EKG strips themselves? So I think the same thing with the imaging is that it really does require a team approach, and there's no one AI that will solve everything, but it can augment and it can enhance the way we practice.
No, that's a very good point. That's a great point. I never even thought about EKGs because every EKG I ever see has its own interpretation, and sometimes when it says acute MI, it kind of piques my, or it kind of makes me look a little bit more closely and say, no, that's not a real MI, or oh yes, it is, and right, and then it can help. So I can see that, and that's a very good point. Could it be too sensitive? You
Mhm.
think like too much, or and that's a really good point about the who's going to be the final adjudicator, and then does that place us or clinicians at liability risk, do you think?
I think it does. I think at the end of the day, it is the provider that's going to be liable. There's always these ethical questions: is it the algorithm, creator? Is it the health system? Like, who's ultimately responsible? Is it the vendor? But at the end of the day, it's going to be the provider to decide whether or not to use the tool, how to use the tool, how to implement it, how to validate it, and whether or not it does help. Or is it so sensitive that it's calling PEs on, you know, 50% of your studies where it's really not? And is it adding more work, or is it distracting from, going down to what's the most important thing?
I mean, that's actually quite concerning. Like if it calls a pulmonary, have they done studies where they compared a radiologist to an AI program, and then how do you know? Like, would you have to then say, for example, an AI program says there's a pulmonary embolism here, or you would look at that same scan, or I would look at that, you, not me, I would look at that same scan, or I mean, you would look at that same scan and say, no, there's no PE here,
Well, I
and
think
then you'd have
that's,
to
yeah.
to go for a pulmonary angiogram to try to say who's right and who's wrong, right? I mean,
Mhm.
there are real world implications to this technology.
Right, there are, and especially if you're again using this, if you're first line, right, and a radiologist is not available to do the interpretation right away, and you're relying on AI, you may be going down some rabbit holes. And like you said, I think there aren't a lot of randomized controlled trials comparing, radiologists to AI, but a lot of the algorithms that have been developed with the labeling of radiologists. So, I think that you have to look at that also. Is who's creating the algorithm? How is it created? Are the data sources available, or are they publicly available to look at and compare and see how did you come up with this, tool to
Right.
detect fractures or to detect hemorrhages? And then to see like, well, yeah, and then what's the ground truth? Like, is a pulmonary angiogram going to be ultimately what's needed to prove that there really truly is a PE? But I think those are all the amazing questions that come out of this, and I think that's why, to answer your initial question, are we out of a job? I don't think so. I think there's going to be a lot of vetting and a lot of back and forth and iterations on these tools here in the short term.
Yeah, yeah. I mean, just in our conversation, it kind of makes me concerned because if you don't have, you don't have a radiologist, and the AI program says, I think there's a PE here, and you start someone in anticoagulation
Right, exactly.
empirically, and then they develop a bleeding complication, and then it turns out that they're wrong. Like, I don't know. That's kind of that's kind of frightening. It's just as scary as when a radiologist misses a lung nodule, right? And then the person develops lung cancer 2 years later, or misses an intracranial hemorrhage, and they start someone on heparin, and then that gets all those kind of things. It's I don't. I think it raises a lot of concerns in my mind.
It does. And the other question is once we have these algorithms, will we run prior imaging through these algorithms to detect those nodules? Or if I had a scan, like would I want AI to take another look at it and see if there's something wrong? And then also, yeah, we're worried about sort of autonomous or immediate diagnosis from an AI in the ED setting. Like you're sort of pigeonholed to act on it if you don't have another opinion, right? So
Right.
I think that gets into very tricky territory, and how do you know when to pull the trigger on to treat or not?
Yeah. I think that needs to be. I think that needs to be outlined, and I think that needs to be defined, and I think that needs to be um, uh, uh, commented on by specialty societies. And I'm sure, are you involved with that with the
Yeah, yeah, that's a lot of
Radiological
what I've
Society of
been
North
working
America?
on. Yeah, especially with like the data sources, making sure that, we are standardizing the way that we label things, that they're available. And how do you improve the algorithm once you develop it? Like, how do you know the different versions and versioning and making sure that it has the latest and greatest and then also the demographics are different, right? What if you have a data set, for instance, that's all say Caucasians, it may not work for somewhere else, like let's say in sub-Saharan Africa or the Middle East or in Asia. So I think that's another big issue is what is the source of that data, and then who does it work for? Is it local data that's for local populations, or is it generalizable? And then we also have the big issue in pediatrics. A lot of these algorithms are based on adult data, and they don't work on pediatric cases or scenarios.
Yeah, yeah. How even just a basic simple question, how does an AI program read the film? Like, how can it detect a nodule like where you can't, or where you could? How does it do that? Is it just
Yeah, so
scan it and go and get um, archives from the internet? How does that work?
yeah, so I think so. The way the algorithms are developed is that they take data sets, so they take imaging, they label them, saying this is a nodule, right? And so the AI system of this neural network that works like a brain starts to understand that these patterns or these things, these ditzels in the lung, are actually nodules. And then when the algorithm is deployed, the whole image set is sent to that algorithm, and it looks through all the images and it sort of highlights what it thinks are nodules, right? And then the question is too will some of these algorithms compare like priors to currents, right? Or has it changed in any way, or does that require also human involvement? So there's a lot of questions, and obviously anyone that does medicine knows that the comparison is worth its weight in gold. When there's, is it something new? Has it been there for 20 years? Those types of things are also not fully addressed by a lot of algorithms today. It'll detect a nodule, but it won't put it into context.
Right. And that's exactly, and you're exactly right. That's absolutely essential, right? If the nodule is unchanged after 6 months or a year, it's one thing. If the nodule is bigger or smaller, that's quite a different thing. Um, yeah. And so you're training the model to this is a nodule, right? And it just
Yes, exactly.
over
Or this is
previous,
this is a pneumonia, or this is the heart, right? There's nothing wrong with this, or this is the thymus,
right,
shadow with the heart. It's not a mass. So there's a lot of little nuances and things that are hard, especially like on, let's say, a chest X-ray versus a CT, versus an MRI. So imagine doing that with all the modalities, with all the data, and having enough data that you can detect normal versus abnormal. But I think that brings up another good point is it would be nice to have an algorithm that can detect normals, right? That you're not looking
right,
for diseases or saying that it's totally fine. There's nothing to follow up here. Or I think that would save radiologists and clinicians a lot of time, that are worried about fractures or other things, and patients too, knowing that these algorithms can detect what a stone cold normal exam.
right. And would you trust it to say that it's normal and just look? I mean, do you think there's a risk of it says normal and then the radiologist says, "Yep, it's normal,"
There,
without
there's
looking at it?
there, yeah, there's absolutely there is that bias that you could over time, this automation bias where you're relying, just like GPS, right? If you're driving, you sort of
Right.
rely, and sometimes people that know the roads know that that's not a good route, or there's construction or whatever it is. And I think we have to do the same due diligence with the AI algorithms, and use it when appropriate, and also making sure that we're using it in the right setting. And like, for instance, like stroke has been revolutionized by some of these AI systems, where they can detect stroke pretty quickly and call the stroke team, in that golden hour. And I think there are
Oh,
things like
really?
that. Yeah, there are things like that that are automating, and they're getting pages, and the AI is sending it directly to the team saying this patient is on the clock.
Oh, that's very interesting. And yeah, it's time is brain
Yeah,
with respect to a
exactly. And
stroke.
so if you have the algorithm that's able to detect that before the radiologist even sees it, it's pretty fascinating. And then also, what's fascinating too is, like, triaging lists of cases. So if I have 100 cases on my to-do list, sometimes the AI some of these AI systems can triage or put the things that it thinks has positive findings up higher. So there's a lot of different ways that AI is going to be interweaved into our daily practice, and we're already starting to see that.
Oh, very interesting. I know that. So, with respect to interpretation, I know, like for in our system, the AI ambient listening applications are starting in the outpatient setting first, then coming in the inpatient setting. I'm using an application when I write my appeal letters that I just talk to it and it generates the letter. It's amazing. It's a game changer from my perspective,
Mhm.
um, because but I'm talking to it and I'm telling it what to say, and I refused. Like I'm a writer and I write newsletters and blog posts and everything. I refuse to have AI write for me. I won't do it. I don't think I'll ever have AI write it for me. Even though one time I had AI rewrite LinkedIn posts and I was pretty impressed by how well it did. I still will. I don't think I'll ever let an AI program write something for me, write an article for me, even it's in my own style. I like to do that. I want to do that. Is that coming, the interpretive part of AI? Is that coming where it'll generate a template for you that you can obviously fix it and make it your own, or is that still out there? That's still more to come there.
No, there's actually a lot of systems like Rad AI or Nuance, PowerScribe, things like that, that are taking what we're saying in prose, and then actually creating an interpretation. Like, so if we just freely dictate what we're seeing, it will put it in a template and put it in a very um, structured way, and also prioritize the impression, similar to how we teach residents and fellows, but it's automating it on the back end. It's still using the inherent verbiage of the radiologist, but it can also help enhance the way we structure it. So the liver is here, the gallbladder, bile ducts, whatever it is, and then the impression where it has the most important thing first. Some of these AI systems are doing that very well. And like you said,
Mhm.
these ambient technologies are very helpful to where you can actually spend more time with the patient, or I can spend more time with the imaging, and not having to be the editor of the report.
And does it still make it yours?
It does still make it mine, and then it'll flag errors, or it'll maybe suggest words that are better, more appropriate, or more scientific, or more medically related, as suggestions. But at the end of the day, it is my product, but it's sort of the tools that we use to enhance it.
So we're going to hold the thought about interpretation because that was the second part of what I wanted to talk about with you as a radiologist. And what have I not asked you that that I should be asking you about AI and radiology technology?
Yeah, I think you've hit on a lot of things. I think we're starting to see this predictive like analytics, like combing through electronic health records, suggesting when patients may be going awry or may need certain studies. So, for instance, appropriateness. When is the right time to order a study? What are the criteria? When should we use contrast? What protocol should we use? So I think even just the pre-ordering process for understanding what imaging technique would be very helpful to a clinician. Should I use ultrasound? Should I use MRI? We get those questions all the time, but I think AI, may have those standardized protocols and based off of the medical record that's coming in from patients. And then this whole like ethical side that I discussed briefly is, where is the data coming from? Who is it applicable to? What happens when it goes awry? Who's going to be responsible? I think there's a whole area in there of, what do we do with that information, and how do we vet it, and how do we make sure it's valid over time. So those are the things that worry me. Even the other day, I saw AI come up on an image saying that there's no fracture. So we're already seeing that being built in, and whether or not, do I have to look harder then to try to find something wrong, or do I just pass it? And like you said, do I just let it go and call it normal? So I think that's, and then how do we teach the new residents and fellows in radiology on how to use these tools? Do we bring them in, and the algorithm says no fracture, or do we have them be the first pass and have them learn like we learned back in the day on how to interpret?
Well,
So
I mean,
yeah.
no, that's a great point. I was thinking like, yeah, we have self-driving technology and auto steer and things that keep your car in the road, but when I'm teaching my kids how to drive, they're not going to use that at all. They're not going to even use, I have an electric car. They're not going to even have them use regenerative braking because they need to learn it the way you're learning without the crutches of technology, right? Isn't that, I mean, that's how I think you should teach someone how to drive. I think you should teach a radiologist how to read it themselves first. What's your thought about that?
Yeah, I'm sort of, I have mixed thoughts on that, because, like, for instance, let's say in surgery, like, do you teach a person how to do an open prostatectomy or an open, appendectomy, whereas you have all these like robotic, and low, small, very minimally invasive type procedures. And I think the
Oh,
same is
that's a good
true.
point.
Yeah, I think the same is true with imaging. Is at what point do we bring in and allow the residents to use the AI, or maybe they have to take a first pass at it before the AI is activated. And so I think the whole education piece hasn't really been thought through. I think right now everyone's trying to reach the holy grail of AI interpreting, reporting, and sending out. And so I think there's different steps that we have to look at and put brakes on some of those, and really do quality assurance and safety checks.
100%. And I hope that I'm glad to know that you are there, and I really hope that they have clinicians every step of the way, because there are, like you said, there are real world implications for everything that we're doing. And I thought prior to having this conversation with you that it would just be simple, but we've raised, I think, maybe 50 issues that have to be addressed, right?
hmm I think so. I think there's a lot of issues, and when a vendor comes in and touts, this tool does X, Y, or Z, how do we know what are the questions to ask the vendor? So I think there's a whole art around bringing in these tools and also knowing when they're turned on, turned off. Can we peer behind the curtain and see like how it was created, who created it? Was it radiologists? Was it orthopedic surgeons? Was it who like we almost like when we were dealing with the data standards is like we almost want an ingredient like list with the
Right,
calories
right.
and what went into it, how many cases was it vetted, and how many, let's say, how many institutions are using it. So there's a lot of little nuances that we would like to know, like what's the background of these tools, like just like GPS, like who created these maps, how updated is it? It's nice to have real life traffic patterns, or is it learning? Is it a learning system over time?
Yeah, yeah. Those are all fantastic points. Going back to interpretation, I know you and I have spoken about this before, off camera. Like, as a clinician ordering a study, when I want a radiology interpretation, I want the radiologist to tell me there's a nodule here. It's this big. It could be this, and this, and stop. There's a pneumonia. It also could be alveolar hemorrhage, or because I'm a
hmm
pulmonologist,
hmm
most of it's lung stuff, right? I don't want the radiologist to tell me surgical consultation recommended,
Right.
bronchoscopy recommended, biopsy I don't want what that's one time I had a young, not a young, older elderly lady who the radiology interpretation said bronchoscopy recommended. And that boxed me into a corner
hmm
that now I have
hmm
to place this patient, elderly, at risk of an invasive procedure because the radiology report said that. And if I didn't do it and something bad happened, then I am put at risk for liability. What's your thoughts about that? It really frustrates me as the ordering clinician. What are your thoughts about as a educator and a radiology leader?
Yeah, I think from my vantage point, I and also with I think it would be much better if we have that ability to create better differential diagnoses, to be more confident in saying, this is a nodule, this is the LIRADS or lung RADS, criteria that it fits, and then leave it at that. Give it a score, give it a standard score, give it a good differential, and then you, as the clinician, should be deciding what next steps. Does it need to be biopsy? Does it need to be followed? I think that's where I tell my trainees, we're not telling you how to practice medicine, and we're
Mhm.
not asking you to treat the image, right? We're trying to give our best, most authoritative approach to diagnosis, and also using the standards that are out there, whether it's liver schema, like liver nodule schema, lung nodule schema, and
Mhm.
and really that's where I see AI helping, is that if we dictate and we say this is the size criteria, this is where it's located in this lobe or it's mediastinal or whatever it is, then it should say like what category it is, right? And I think a lot of us are really trying to get to that point, but it's all over the place. It just depends on the radiologist you have that day. Some are lung trained, or that they're pulmonary trained, and some aren't. So can
Right.
it equalize the playing field? There are some people that are very wary of interpreting pediatric studies because they don't see children. So it may be helpful to have that crutch or that AI algorithm to help. And I think that's where you start to see like surgery consult requested, or you start to see CYA, type of medicine being
Yeah,
practiced.
why? Like I was going to ask, why do they do that? Like, why is it? Where? Why? What? Why is it your job to tell me to call a surgeon when I'm the one ordering the scan because someone comes in for abdominal pain, for example? I'm worried about a perforated viscus. I ordered a CAT scan of the abdomen or an upright KUB. I see free air. I'm the one that has to make the next step. The radiologist tells me there's free air under the diaphragm, or the CAT scan, there's free air here, and it looks like there's a perforated duodenal ulcer. stop. My
Yeah,
job
and,
is then to
and
do
I
what's,
think,
why do you
yeah,
tell me to call a surgeon?
yeah, I think one of the big issues is sometimes we don't know our audience. There are individuals that may not know, and this has happened in a training setting where a perforated hollow viscus may sound like, something in passing, but it is very important that requires surgical consultation. I think that's where people have gotten burned, or where there's a communication piece. There's like when I tell you there's a pulmonary embolism, it automatically triggers something in you, but it may not for let's say a first year internal medicine resident, or it may, that's getting that message at 3 in the morning. So I think there's context, but I think there's like we can't work in silos. Like we have to I'm hoping AI bridges some of those communication gaps, and I think that's why you're starting to see that's why you're starting to see like shotgun approach, saying everything, because you have no idea. You have a disconnect from the ordering provider and the interpreting radiologist.
And I was going to ask that. So do you think I should go down to I mean, I may not be able to practically go to the radiologist and look at every single film every single day. And I know you are busy as well, having to interpret a lot of films, especially if they're in the emergency department and their stats and there's an urgency. And do you think I need to get over my laziness and go down to where my radiology colleagues are and discuss films with them?
I think it does help in certain scenarios, and I do see that interacting with oncologists and other people where there's a dilemma, where there's a question, but also like even giving feedback on, if you see a study that's from me, I really don't need that additional like, recommendation for consultations to surgery or oncology or biopsy. Like
Mhm.
those things, I think even just picking up the phone and saying, I fully understand what you're saying. You really don't need to add that to my future reports. I think, like I said, I feel like there are people that are just living in a dark room, reading a lot of studies that don't get that feedback or interaction, and so we sort of lob it over the wall and let somebody else take care of it.
Oh, I see. Yeah.
Yeah,
I
but
think,
I
yeah.
think if we break some of those walls, I think even just a simple phone call or follow up questions. I mean, it doesn't have to be in person. One thing that we're trying to create also is like a consultation via video conference, like where we can pull up the image, we can discuss it. You don't have to be in proximity, but I think it's so easy to pull up a Teams or a Zoom and pull up a study and discuss it with that clinician at their leisure, even on their phone.
Yeah, no, that's a very good point. And I think, again, I'll fully admit sometimes I just don't want to go I mean, I'm busy in the unit, I have things to do, and I
One
just don't want to
hundred
go
percent.
all the way down to
Yeah.
the.
But I think that's something that as an informaticist, I would love to see where we leverage those tools, the electronic tools, to bridge some of those gaps and have a better understanding on who's reading our reports or who's giving us feedback and whether or not feedback is necessary. I think it's essential. Just like you would want to know if you made a mistake, I would want to know if my interpretations are wrong or I said something egregious or a follow up saying you made a good call. So on both sides, we oftentimes don't get that unless we search for it in the medical record or we look for follow up. Like what was this nodule malignant or just a granuloma from living on the Mississippi
Right,
Delta.
right. It would be interesting to have AI do that, right?
Yeah,
AI to look at the biopsy result, if it could smart enough to look at the biopsy result, match it to where it was, right, where it came from, and say, this is a granuloma, or
yeah,
this was a.
and this is the beauty of AI is that people are looking at, let's say, brain tumors and feeding it what the pathological diagnosis is, so that once the AI sees that type of tumor again or that location or has those imaging characteristics, it can actually say this is a GBM, this subtype. That's what we're working toward is being much more accurate in differentials and giving people not only just malignant or benign, but actually down the roads of what type of benign lesion or what type of malignant lesion. So
That's it. Oh, wow. Do you think that one day it could take the place of a biopsy? That kind of makes me nervous, right?
yeah,
You
I
got
mean,
to see
people
tissue.
are calling those pixel biopsies, right? And it could take the place where where that becomes very important is where you can maybe start treatment right away before you have a tissue sample.
Right. Because I know
Depending
like a lot of
depending how
times,
on how yeah on how accurate and how confident you are in that diagnosis.
yeah, because like for example, you have radiation therapy for an obstructing tumor. They always say, well, we need the tissue first.
Right.
But if it's very accurate and trusted, you can start radiation right away
Yeah,
to give.
and that's and then we're getting into things like image markers and other types of higher level physiological imaging, which is very fascinating too, which we haven't even touched on. But I think the AI could be an intermediary before we get to that point too.
Oh wow! So are you as we conclude, are you excited about the future with AI?
I'm actually I'm very excited about the future of sort of imaging and just screening in general. You know, whether it's digital pathology, whether it's visible light with dermatology. I mean, we're seeing things where the AI is able to diagnose melanoma versus other lesions, but we're seeing more and more of this where it could get down to the consumer level where you could take a picture of a skin lesion, or you can take your own imaging and run it through, let's say, an algorithm. It'd be very fascinating to see, like, empower people to help make their own diagnoses and to validate, why you're going to a specialty, care service. So I think it'll empower both clinicians, patients, and healthcare systems, but it has to be done with caution, and there have to be safety nets around that, like we talked about.
Yeah, yeah. Because I can't even imagine now. Radiological WebMD. I'm not picking on WebMD, but you always cringe when you have a patient armed with a printout from a website. I can only imagine the complexities that would introduce to practicing clinicians, right?
It does add complexity. Even the chat GPTs and Claudes or Geminis are adding to that now too, where people are saying,
Right.
I have these symptoms. What do I have? And what medicines should I use? And so it's going to need somebody that can, like, hold their hand and to figure it out.
Yeah, absolutely. Do you think one day we'll have a thing like in Star Trek, or where they just
The
scan your
tricorder,
body and
yeah. I mean, I think that's
they can
what
tell you
people are
what it is?
trying. Yeah, I think that's what people are trying to develop. And these are some of the tools that were in Star Trek. But like I said, I think they're sort of one-offs. I think that we still need somebody like very astute to synthesize it and put it all together and to make sense of it and put it into a very clear and coherent plan for a patient. But I think this is just one tool, just like many other tools that have come up, the generations and decades. It's another tool that we have to vet, and it will be an important piece, just like it is with everything else that we're doing in life. But I think that there's a lot of hope around it, and also hopefully that we can look at like preventative care and also avoiding imaging that's unnecessary. I think that's a
Mm.
huge piece that we haven't really even talked about. Is not only saying that I don't know, but saying you shouldn't do X, Y, or Z, or and being monetized and being incented to not do certain things.
Right, right. Because I don't think we're getting the implications of all the radiation that we're exposing patients out of fear of liability, and I'm first
That's
one to
exactly
admit that.
right. And the thing is that I may recommend an ultrasound or I may recommend something that's less radiation to get to the same diagnosis. But again, that all depends on the resources you have at your institution, how well you trust your technologists, your radiologists, and also like what the patient population is. If it's outpatient, run of the mill kind of stuff versus people that are doing liver transplants and kidney transplants, it's a huge difference in
Yeah,
in
yeah.
in type of practice. So that's why I think these generalizable AI systems are not one size fits all, but it can be very useful in places where you don't have that high level radiologist or subspecialist.
Yeah. Wow. Phil, this is a fascinating conversation. It's really there's a lot of issues you raised. Again, I'm very happy that you are there at the forefront trying to help make sure that these systems do the right thing and rather than do the wrong thing. And so thank you for all you do. Thanks for your time, Dr. Safwan Halabi. It was an honor having you on Healthcare Musings.
Thank you so much, Shem. I really appreciate it, and I appreciate the time.
Absolutely. Thank you. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.